Hello, my name is Ken Gordon. I'm the chair of dermatology at the Medical College of Wisconsin in Milwaukee. And I'd like to talk for a few moments about what are sort of our ambitions. Where's the direction we could get in plaque psoriasis and psoriasis in general over the next 5 to 10 years? I think it's a little different in psoriasis when we look at having very high level efficacy in our medications right now. We are hitting PASI 90s in clinical trials at approximately 80% of patients in some of the newer medications, even higher in some. So we have to look at where we're going to go in terms of improving upon that. And I think there are three basic areas we can look at. The first is in patients with more limited disease, how can we find new topicals that'll be helpful to patients? Because while we always talk about systemic medications and how we're treating patients with very severe disease, most patients have relatively limited disease that are amenable to topical therapy. And we really haven't seen a lot of progress in topical therapy since, to be honest, the 1960s and 1970s when topical corticosteroids came out. We've had some improvements with topical vitamin A and vitamin D derivatives. And there are two new pathways that are being tested right now that will hopefully make additions. But still, the mainstay is still topical corticosteroids. And so as we develop new agents for topical use, it's really going to help a lot of patients, and many will not have to go on systemic therapies in the future. And I think that would be a major advance. The second area is in systemic therapy for people with severe disease. And how do we think about the best way to treat patients, not as using chronic therapy at all times, but are there things we can do to stop and start treatment? I think the ideal we would look at is trying to say, are there medications we can give and give prolonged responses off medication? We see that a little bit with anti-IL-23 agents, but still looking at agents that might, for example, impact the T suppressor system and regulatory T cells might give us a chance to give medication, get patients better, and then leave them off treatment for extended periods of time. And I think if you think about patients and that their ambitions, the first question they ask is, when can I get off this medication? Having a time where you could do that would be a great advance for our patients. The other option to think about is, can we give patients medications that will work quickly and repeatedly, where if they're doing well, they can go off treatment and then retreat when it comes back. And one thing we have to remember in plaque psoriasis, unlike inflammatory joint disease, is we really don't worry about long-term disease modification or changes in permanent effects like joint space changes that we can't reverse. Almost everything, at least clinically in psoriasis, is reversible. And so if we could give medication, stop it, and then only give it when the disease comes back, patients would be able to have periods where they're not on medications. And I think that is something, especially with new oral medications that might be more amenable to stopping and starting, is something that could be a clear benefit. The last area I think we still have room to go, and I think we have to work on, is special areas, particularly the palms and soles. Those are areas that biologics really don't work nearly as well at. And we have to get medications that can penetrate these areas where the skin is a little bit different and be able to show some improvement. Some of the ideas that people have had is using small molecules, JAK inhibitors, for example, that haven't been tried on those areas, but might be something of significant benefit. Or alternatively, small biologics, small peptides that might block our targets and then be able to have some improvement and be able to penetrate these very difficult areas to treat. So while palms and soles are the primary areas we worry about, but you can think about patients who have difficulty with inverse psoriasis, genital psoriasis, or even scalp, though not so much in the scalp, and needing to find new areas and potentially new drugs that can attack the mechanisms in a way that will work in those special areas. So if I really had to think about where we're going in the next 5 to 10 years, where I would hope we would go is, as I said, finding new topicals that can be helpful for patients. 2, being able to find medications that will give prolonged responses even off medication. 3, developing protocols with existing medicines or new medicines that will allow people to be off for periods of time and be able to have consistent treatment thereafter. And finally, finding ways to treat specific areas, particularly the palms and soles, and getting patients to have relief in those areas that are actually very critical to them.